Well, a very good afternoon to everybody. And first of all, I thank Dr. Nitin Balkrishnan for having invited me here for this instruction course. Well, old as gold. Rupal just asked me, where's all the gold? So I said, I have come to Calcutta and I need to buy some more gold. I'll do that after the session. I have no financial disclosure. Well, there are many microkeratomes which are available today in the market, just to name a few. Yes, there were problems with older microkeratomes. We got thicker flaps, because of which the stromal bed to work on was less. So it restricted the number of patients that we could treat, and we had ectasias. We had unpredictable flap thicknesses. Epithelial defects, abrasions were some of the problems. The assembly was usually on the eye, which was time consuming and also gave rise to less predictable outcomes. The superior hinge was the norm at that time. This caused dry eye. The reason being that the long posterior corneal nerves, which innervate the cornea, enter at the 3 and 9 o'clock positions. With a superior hinge, both the arms of the neuroplexus are transected, and which over a period of time, with newer microkeratomes coming in, we shifted to the nasal hinge and the dry eye symptoms automatically came down. There were also problems when we were dealing with smaller eyes, people with small palpebral fissures. I remember times when we had to make canthotomies and things like that because we would lose suction. There were problems with small eye and no proper exposure. There have been various comparisons which have been done between so many microkeratomes, and it was seen, this was a study done in 2004, where the results demonstrated variability in all the different models. The thinner corneas were associated with thinner flaps and thicker corneas with thicker flaps. First cuts were generally associated with thicker flaps when compared to the second cut. But microkeratomes evolved. I think many of us here who have been in refractive surgery for some time, we've gone through this phase where we were dealing with metal heads. We had to assemble the blade into the metal head, and so it was more time consuming. Cornea was not visible when the cut was being made. Whereas then came the disposable heads, which made life a little more easier. We didn't have to do this assembly, but it still involved an assembly on the eye where after the suction was applied, then we would put on the microkeratome onto the ring. But again, evolution, and this is just an example where the SBK sub-Bowman's keratomiliosis came in, and it's called the one-use plus. So the flaps became thinner. They also have an epileptic version where the flap can be still thinner. As I said, the nasal hinge is definitely better than the superior hinge. Less assembly time, and there is no assembly on the eye. So on the eye, in quick suction, the microkeratome passes through, makes the cut, and we are out quickly. It fits onto any eye. Sometimes we've had cases where we are not able to put the suction ring on properly. So we remove the speculum sometimes, and we are able to get good suction because we are working in the horizontal plane and not the vertical. So we are able to have good flaps in spite of small eyes. So the newer microkeratomes, if you compare, they became thinner. We got better nomograms, so better predictability, and accuracy also improved. There have been studies which have been done where femtosecond flaps have been compared with the microkeratome flaps, and as you can see here, that the first eye and the second eye, there were not too many differences, and neither was there much of a difference in the femtosecond versus the microkeratome flap as far as thickness goes. As far as the hinge position, also the nasal hinge worked better. Any procedure has complications. So buttonholing, the incidence is more when you go thinner and when you use the same blade for more number of cases, but in general, the incidence of buttonholing is 0.26. Epithelial defects also, the incidence being 0.24. Epithelial ingrowths in primary cases 0.9, and as the surgeon just said now, about 1.5 to 2% in enhancements. Difference in the flaps in microkeratome and versus the femtoflaps. In the microkeratome flaps, if you look at the corneal morphology that, or the changes that occur in the cornea, there is a programmed cell death or apoptosis as it is called in the corneal stroma in microkeratomes, whereas there is cellular necrosis which releases lysosomal enzymes which trigger the inflammatory cells. In microkeratomes, the flap margin showed a very ill-defined fibrotic scar with no epithelial plug, whereas with the femtosecond, it showed that there was secondary fibrosis along a well-defined edge with an epithelial plug too. And there was tissue loss, as it is seen there, that the tissue loss is seen initially in the initial phases with a femtosecond laser. There are complications which are specific to femtosecond lasers itself, like transient light sensitivity syndrome, the rainbow glare, opaque bubble layer, epithelial breakthrough of the gas bubble itself, and gas bubbles within the anterior chamber. This opaque bubble layer obscures the fixation target, so your next procedure of doing the excimer laser is hampered. The pupil centration, especially when the pupil tracking occurs, there is, it's not very well seen, and also for cyclotorsion, the iris gets obscured. The vertical gas breakthrough is similar to a buttonhole in microkeratome flaps. DLKs, because of the inflammatory response, which is more in a femtoflap as compared to a microkeratome flap, the DLKs were more, but it was seen that once the energy levels in the femtosecond lasers was increased, this incidence of DLK came down. Another important problem that is faced is that the flap folds which can occur in femtoflaps are much more difficult to treat as compared to microkeratome. The dry eye, when you compare microkeratome to femtosecond, the corneal sensation and dry eye symptoms were present in both the groups up to about 6 months. Visual outcomes, there was no significant difference in predictability and uncorrected visual acuities, and even the higher order aberrations were similar. Now, coming back after all this exercise, just to sum it up, microkeratomes, after having been evolved, are much more predictable, they are more planar, there are minimal complication rates, less incidence of dryness and comparable with a femtosecond, great visual outcomes also comparable, and less incidence of high order aberrations or almost equal to femtoflaps. Femtoflaps, complications of their own. It can be more time consuming. There is still a learning curve, which is there of course in every new procedure that you do. More space required, which can be a constraint for many of us. And the most important, the cost factor. A microkeratome will cost you around 20-25 lakhs, whereas a femtosecond laser will cost you around 2 crores. There are also recurring costs like the blade costs, the air conditioning which needs to be on 24 hours for a femto, and also the AMC, CMC costs which are involved are much higher in a femtoflap. So the question is, do we really need the femto laser to make the flaps? Are they really worth it? Do we really earn anything at the end of the day? Are we just earning for the company? Are we reducing our lifespan by increasing our stress levels? This is my big question. Thank you very much.